for question and answers. I think it's a very interesting talk, and we have a lot of experts in this session that, you know, I think they'll have lots, hopefully there'll be a lively discussion at the end that we can all learn from. Feel free to raise your hands or use the chat box. You can write your name so that we know who's asking a question, and then you can type in your question. And you can do that as the talk is ongoing, so that I'll take note of that, and then we'll moderate that towards the end. All the talks, I think for this one as well, will be available on the website that's shown here. And so will be recorded, and the script and all the video will be available at this link here. So, yep, so we'll just go ahead and start. I'm very, very excited to present Professor Kishore Kumar, who is consultant neonatologist at the Cloud9 hospitals at Bangalore, India. He is also the founder and chairman of the Cloud9 group of hospitals in India, as well as adjunct professor in neonatology at the Notre Dame University in Perth, Australia. He sent me a very lengthy CV with lots of awards, but I think for the purpose of this talk and time, he's been involved in many committee work at the national level in India. And today he's going to be presenting a talk, I think that's going to be very relevant to a lot of us here. Can babies with pulmonary hypertension survive without nitric oxide? So over to you, Professor Kishore.
Thank you. Thank you, Ki. I really appreciate for the kind introduction, and definitely this is a talk which raised a lot of interest when Julie and Azana initially listed this as a topic for the neonatology conference in Kuala Lumpur 2 years ago. And it has taken a good shape since then because of various reasons which I'm going to address. My job is very easy because we have the experts, the Trimurtis, Praveen Chandrasekharan, Satyan, and Steve Abman here, who can give the comments at the end of my lecture. So I'll just set the stage for the topic, which is basically, can babies survive without nitric oxide? For those of you joining from India, Malaysia, and Singapore, good morning. And for Indonesia, Australia, New Zealand, good afternoon. And Praveen, Satyan, and Steve, good evening for you. And thank you for keeping your candles burning in the midnight. For those of you who don't know India, India is a huge country. And it's almost like Europe being a single country. So you can imagine the multiple states, we call it. And each state represents almost like a single European country. What it means is the culture, language, various things are different. So if we do a good multi-randomized center research in India, it reflects a lot of cultures and a lot of population and the genetic variation. So with that, I would like you to welcome to Bangalore. Bangalore is a very, very cosmopolitan city. And the weather here is 22 to 28 degrees Celsius, almost 10 months in a year, which I'm sure you won't get any part of the world. 2 months in a year, it's either hot or sometimes it's rainy, but otherwise you really enjoy a beautiful weather in Bangalore. And I don't have any disclaimers, and I definitely don't have any financial interest, which I can declare here apart from me being the chairman of the Cloud9 group of hospitals. Neonatology is a
Sorry, Dr. Kishore, we can't hear you. Could you please unmute yourself? Yeah, thanks. Dr. Kishore, we can't hear you. Could you please unmute? Yeah, we can hear you now. Yeah.
Were you hearing till now, or were
yes,
you not?
yes, yeah.
Okay. So something happened in between, is it?
Yes, yeah. Sorry about that.
That's okay. Neonatology is one of the youngest branches of medicine. Many of you know, being neonatologists, it's just 60 years old or 6 decades old. And many of the protocols which is used in neonatology is evidence-based medicine. In that way, we can boast ourselves as neonatologists practicing evidence-based medicine. And if you look at the various major milestones in neonatology, it's really in the last 40 years which has really revolutionized the most of the treatment with the surfactant, ventilation, antenatal steroids, and various things having revolutionized the neonatal care. The World Prematurity Day was recognized as a significant event and started only 10 years ago, though we have been saving premature babies for quite some time, which clearly shows we are a very, very young branch of medicine. What is important in neonatology is healthcare delivery and outcomes. We need to follow the standard of care because healthcare delivery is very complex. It cannot be standardized like unlike a airline industry or a IT industry. How will you standardize a particular patient's response to a particular medicine or a drug or a vaccine? And you can't guarantee that. And each person is different, each situation is different. So as long as we follow the standard of care, we should be okay. Now, currently the standard of care is, we all know that for PPHN, inhaled nitric oxide is the treatment of choice. Now, we will talk about the problems and all the other alternatives in the next few minutes. But before we do that, I just wanted to highlight the causes of PPHN in newborn, and the two causes which a lot of us as neonatologists know, but many obstetricians may not be aware. So we have been starting to highlight these points to many of our obstetrician colleagues, which has helped us in a big way. One is a maternal use of non-steroidal anti-inflammatory drugs with the in utero constriction of the ductus arteriosus is causing, and late trimester selective use of selective serotonin uptake inhibitors can reduce the PPHN in term babies. And definitely PPHN is a multifactorial things, and the incidence is supposed to be anecdotally much higher in Asia compared to the Western world. And I'm sure all of you know Satyan's famous slide, which shows the causes of hypoxic respiratory failure, which leading to PPHN. And this complicates the hypoxic respiratory failure to the extent of 75 to 80%. Nitric oxide is a colorless, odorless gas, and it was recognized as a key endothelial-derived vasodilator molecule in 1987. It was used initially to avoid putting babies on ECMO, because before 1987, any baby who had a severe PPHN and oxygenation index of more than 40, the only way the baby could be saved was to put the baby on ECMO. And as you all know, ECMO is one of the things which we all would like to avoid if possible for various reasons. Finally, the nitric oxide was licensed by the FDA in 1999 for limited use in PPHN. But the problem with the nitric oxide was it was used in a dose of 20 parts per million, and higher doses were associated with methemoglobinemia and increased level of nitrogen dioxide, which itself is a pulmonary irritant. So if you look at the nitric oxide, it is not the magic bullet which we all think it is, because 30% of babies don't respond to nitric oxide, And I'm sure all of you know the causes of the failure of babies not responding to nitric oxide. I'm not going to talk too much into this, but clearly it is evident that not all babies respond to inhaled nitric oxide. Now, I'm sure all of you are very familiar with this paper written by the trio who are present here, Chandrasekharan, Lakshmi, Satyan, and Steve, the absolute contraindications for the use of nitric oxide. I have added a few relative contraindications to this list, especially for people from the Asian subcontinent because of the cost and also the medical grade inhaled nitric oxide being not available in many Asian countries. Now, if you look at what is the difference between a medical grade nitric oxide and industrial nitric oxide, all the Asian countries get industrial nitric oxide, which is not the same as medical grade nitric oxide, which is produced carefully under controlled conditions and diluted with pure nitrogen and stored in the absence of oxygen. Now, what does this mean? And obviously, if it is an industrialized nitric oxide, the impurities are much, much higher. So the possible side effects of inhaled nitric oxide are much, much going to be significantly higher. So just to make you guys think that 1980s preterm babies were being ventilated. And those days, there was no alternative other than ventilation. And CPAP, surfactant, high flow nasal cannula, oxygen, antenatal steroids, a lot of these revolutionized the management of preterm babies in the last 2-3 decades. Now, if you look at the PPHN management, in the 1980s, we used to manage PBs with the ECMO, and then came the nitric oxide. And nitric oxide was used, especially if the oxygen injection was going higher and especially more than 40 to avoid babies being put on ECMO. You mean to say in the last 22 years, we have not had any new therapies? So that's what we are going to touch upon. Again, I'm bringing the cartoon from Satyan's articles, which is very familiar with many of you. All of you know that there are multiple sites where the multiple drugs can act, helping the pulmonary vasodilation. So again, I'm not going to go into the pathophysiology of this. I'm going to talk about the drugs which are available and have revolutionized the management of PPHN in the last 2 decades. Now, inhaled nitric oxide is currently regarded as the gold standard therapy, but with as many as 30% of babies failing to respond, it has not proven to be the single magic bullet. Secondly, the cost is exorbitant for especially countries like India and any Asian countries. Given the complex pathophysiology of the disease, any such magic bullet is unlikely in the near future. That's what they used to think in early 2000s. But then came sildenafil, which is a specific inhibitor of cyclic GMP, and endogenous nitric oxide being a potent vasodilator exerts its action through soluble granulate cyclase. And sildenafil has been used in the treatment of PPHN since 2004 in adults. And in adults, it has been used in oral, intravenous, and inhaled form. Unfortunately or fortunately, in neonates, we have evidence of it being used in oral and intravenous form. I could not find any significant research articles being used in the inhaled form. Sildenafil is rapidly absorbed and it has a bioavailability of approximately 40%. And usually it shows response within 2 hours of oral administration. It is metabolized via the hepatic cytochrome P40, P450, and half-life is approximately 4 hours in adults and excreted in the feces 80% and urine about 13%. Now the first trial of sildenafil came from Colombia by this Ahmad Solis, who published his article in Pediatrics in 2006, where he treated 6 infants with the placebo and 7 infants with the sildenafil, whose oxygen index was more than 25 at 25 hours. All infants were severely ill, and intragastric sildenafil and placebo were well tolerated. In the treatment group, oxygen index improved in all infants within 6 to 30 hours, showed a steady improvement in pulse oxygenation saturation over time, and noticeable effect on blood pressure, and 6 of survived in the sildenafil group, and in the placebo group, only 1 of the 6 infants survived. Following this, multiple studies came into vogue, but most of these studies were from Mexico, Turkey, and Qatar. And finally, FDA officially licensed its use in neonates in 2012. European agency approved it in 2011 and Japan in 2008. So now it is an officially licensed drug which is used both orally and intravenously. And recently we had a Cochrane review by Ann Olson, who did the Cochrane research and showed there were 5 eligible trials that enrolled 166 infants. And most of these were low evidence, and they have been carried out in Mexico, Colombia, Turkey, and Qatar, as I mentioned. And sildenafil was used in the treatment of PPHN here, and they had a potential for reducing mortality and improving oxygenation, where in remote resource limited settings where inhaled nitric oxide was not available. I have to point out that most of these studies were done in centers where they didn't have facilities for either ECMO or inhaled nitric oxide. So they used this as one of the last resorts, basically, if you want to call it. And then we had another study by Lara Shekhar-Diman, who used intravenous sildenafil, which definitely showed significant improvement in the sense that it completely reversed the vascular resistance within 1 hour of commencing the infusion. So in other words, if you look at the literature, oral sildenafil shows a response within 2 to 3 hours. Intravenous sildenafil shows a response within 1 hour of commencing the infusion. And sildenafil intravenous use was also shown to increase the cardiac output by about 30%. Now, if you look at the literature, which Ann Olson has done with the Cochrane review, clearly the forest plot shows that the sildenafils versus a placebo all-cause mortality was significantly higher in the placebo group compared to the sildenafil group. And if you similarly look at the oxygenation, definitely oxygenation improved within 1 hour of giving the sildenafil intravenously and 2 hours orally. And if you look at the oxygenation index within hours of treatment, the multiple studies have confirmed that the oxygenation index definitely improved in these babies with the sildenafil. So there is enough evidence now accumulating and more accumulating over the last few years and decades about the benefits of sildenafil, and definitely the effect on change of oxygen index within hours of treatment is substantially evident. So having this amount of evidence, the most of the Asian countries have now switched over to using sildenafil in their first line of treatment for management of PPHN. If you look at all-cause mortality, as I mentioned earlier, it is definitely significantly better. And when you look at the cost of treatment, in India, the cost varies from $0.27 US for oral management to $27 for intravenous management of PPHN, as opposed to $300 to $400 per day with the inhaled nitric oxide. Now, coming to other drugs, if you look at the other drugs, PPHN clearly shows the world is divided, because if you look at the sildenafil, most of the evidence comes from the Asian and the Middle Eastern countries. And if you look at milrinone, for example, a huge evidence comes from Canadian neonatologists reporting a higher use of milrinone. For some reason, the rest of the world, the milrinone publications and usage is not as much as Canadian neonatologists. Again, inhaled prostacyclins and other things have been used in the Canadian group. So despite the recent advances in the management of PPHN, the risk of mortality and morbidity remains static in most countries. The characterizing variation in practices is a crucial step towards improved patient outcome. And we as neonatologists all over the globe have to come to terms with standard care of therapy, so that, as I mentioned earlier, healthcare has got a standard protocols to be followed. And we have to start making a standard protocol which can be used globally rather than selected few countries. Now, coming to the drugs available for the management of PPHN in the newborn, in the last 2 decades, the drugs which are available for the management of PPHN has expanded exponentially, and definitely we don't have to be dependent on inhaled nitric oxide with its limitations. So I'm going to talk about briefly about milrinone now, because milrinone has been widely used in a lot of centers in Canada, and as a result, a lot of centers in Asia have been using it nowadays. Not much of use in many American and European centers, but it is a selective phosphodiesterase inhibitor with inotropic and other properties which benefits the PPHN. It is definitely a selective phosphodiesterase inhibitor with a pharmacological effects, including relaxation of vascular smooth muscle and enhanced myocardial contractility. A significant amount of work has been done by Patrick McNamara, who many of us know in the neonatology circles. Certainly, this study done by Patrick McNamara laid the foundation for it to being approved, milrinone, as a drug of choice for management of PPHN in 2010. And definitely it was a study which included infants more than 34 weeks of gestation with a birth weight of more than 1,500 grams. And the median ages at administration of inhaled nitric oxide or milrinone were 7.4 hours or 7.5 hours. And all patients required 100% oxygen prior to administration of inhaled nitric oxide. And there was no interval improvement in median oxygenation in these groups. And the infant received intravenous loading dose of milrinone at 50 micrograms per kilogram over 60 minutes, followed by maintenance infusion. And this led to an improvement in PaO2 and a sustained reduction in FiO2 and oxygen index over the next few hours. Hence, subsequently, many studies came into vogue, and milrinone finally got licensed for PPHN management in 2010 all around the world. Since then, it has been widely used in quite a number of countries, and certainly India is one of the countries where it is used rampantly in many centers. Next, coming to bosentan. As I mentioned, I'm going to briefly touch upon the various drugs which are being used and be available in the current market so that we can have time for discussion with all the experts being present here. And as you know, bosentan has been used for effective treatment of PPHN in adults for over 2 decades. It is very safe and effective treatment to improve oxygenation. And it can be used as an adjuvant therapy with inhaled nitric oxide. Many of the studies in neonates has used this as a adjuvant with the inhaled nitric oxide rather than as a primary drug. And definitely Moore et al. Identified it in a systematic review of randomized cluster randomized controlled trial that bosentan is quite safe and effective if used in late preterms and term babies with the PPHN. And both studies reported that bosentan was well tolerated and there are no major adverse events. But not all studies have reported bosentan to be very safe. In fact, the Future Trafo trial, the multicenter study where INO and ECMO were available, bosentan was used as adjunct therapy, and they reported significant side effects, including some babies having liver failure and unexplained cirrhosis. So it is a drug which cannot be probably recommended as a first-line therapy, but it has been used as an adjuvant therapy when either sildenafil or inhaled nitric oxide is not enough, and it definitely works as a good adjuvant therapy. Now, coming to other drugs, we have plenty of other drugs which are used in the management of PPHN. And definitely bosentan is one of the cheaper drugs, if you want to call it. And it costs roughly about 1,150 rupees, which is less than $10 US for the management of PPHN in the newborn. And as opposed to, as I said, $300 per day with the inhaled nitric oxide. Now coming to prostacyclin. Prostacyclins are used because they're a vasodilator by activating the adenylate cyclase. And it has been used both in intravenous and inhaled forms, and 3 different prostaglandin analogs have been approved by the FDA for use with the pulmonary hypertension. And one is ipoprostenol, which is the intravenous injection. Second is the iloprostenol, which is an inhalant solution. And the third is a treprostinil, which is extended oral release tablets. Not many studies in newborns for difficulty in recruitment, but I'm going to touch upon the few studies which we have where we have used prostacyclin briefly, and definitely the synthetic analog of prostacyclin which has been used is treprostinil, and the brand name is remodulin and orinitram, and it has been used intravenously, and the dose which has been used is 11 to 105 nanograms per kilogram per minute. And this has shown significant improvement in both oxygenation index and oxygenation of the babies when it is used, including a good increase in cardiac output and reducing the lung shunt function. And hypotension has not been a problem in these studies, which has been used in many studies. The evidence for tadalafil as initial therapy has been shown in a lot of Middle Eastern studies where it was used and it was shown to be safe and well tolerated. Nausea was the most common reported adverse events in adults, but not necessarily in the newborn. And definitely the cost per day of this treatment is 0.5 US dollars, 0.5, not even $1. So it is a significantly cheaper alternative to use in many situations, especially in the resource poor countries. Ipoprostenol is another analog of prostacyclin. It is a metabolite of arachidonic acid. It causes direct vasodilation of pulmonary and systemic arterial vascular beds. And it has been used quite a lot in adults. Recently, there has been enough evidence accumulating its usage in newborns. And the cost for this is again $0.8 per day compared to the inhaled nitric oxide. And it is available in the trade name as Flolan in India. And definitely it is used intravenously. Iloprostenol, as I mentioned, is one of the inhaled prostacyclins, which has been used in quite a number of studies. And they used this as adjuvant therapy who did not respond to inhaled nitric oxide alone in a study done by Verma et al. And they concluded that inhaled iloprostenol is well tolerated and seems to have beneficial effects in improving oxygenation in disease with the PPHN who do not respond to inhaled nitric oxide. So coming to the poor man's drug, I call it as a poor man's drug because magnesium sulfate is one of the drugs which has done wonders. It was the element of the year in 2015, and it has been used significantly for neuroprotection by our obstetrician colleagues. But its usage in neonates for some reason is limited to Asian subcontinent. And Bu et al. Used it in babies who did not respond to inhaled nitric oxide alone. And there was a large randomized control trial involving 200 neonates by Shalhout et al. where they used magnesium sulfate to the dose of 200 milligrams per kilogram. And they showed a significant improvement in oxygenation and also reduction in pulmonary vascular resistance in a prospective randomized clinical study. And so it has re-emerged as a drug of choice in many Asian countries. And the cost of this is definitely $0.1 per day compared to many other drugs. So magnesium sulfate has definitely been used in the nebulized form, and it may be effective therapeutic modality for neonates with a significant PPHN. And this has been confirmed in larger studies in the Middle East by Mahmoud et al., who have used this in the inhaled form. So coming to other drugs which are used to treat pulmonary hypertension. And there has been quite a number of papers with the various drugs used in combination, either as sildenafil and bosentan and tadalafil, or alone or adjuvant therapies with the one other drug. And definitely it is an alternative to use against inhaled nitric oxide. Now, there is a comparative study of inhaled nitric oxide with the intravenous nitric oxide, which has been used in the porcine model by a Swedish study, where they have shown that intravenous monoorganic nitrate releases nitric oxide inside once you are given this as a drug as intravenous. And this probably, if it's going to be proven in humans, may avoid the problems of industrial inhaled nitric oxide in resource poor countries. And the cost of this drug is supposed to be much cheaper than inhaled nitric oxide. And this may definitely revolutionize the treatment in the near future. There are newer therapies being tried in around various parts of the world, including citrulline, antioxidants, and various other things, but they're all in early stages of trials and not much evidence currently exists. Last but not the least, the Boston team have designed and developed, tested a simple economic nitric oxide generation device, which uses pulsed electrical discharges in air to produce therapeutic levels of nitric oxide that can be used for inhalation therapy. So this avoids the usage of storing of nitric oxide and availability of medical grade nitric oxide in Asian countries. They are claiming in their preliminary publication that the cost of this treatment can be 1/10 of the inhaled nitric oxide. If this were to be true, and it is available, it is going to revolutionize the treatment of PPHN in the near future. So with all this, all that I can say is nothing is permanent. Everything is changing, and inhaled nitric oxide, which is currently supposed to be the gold standard of therapy in newborns, may not be the case in the near future. Julie Woyi and the team have clearly looked at the nitric oxide survivors who have shown increased risk of childhood cancer. So it may not be the best drug to be used in PPHN. And certainly we talked about affordability, and most of the drugs which we use for PPHN, currently the newer drugs cost anywhere between $1 to $10. And the new inhaled nitric oxide in Asia costs anything about $300 to $400 per hour or per day. So certainly the use of nitric oxide is not the optimal drug in Asia and resource poor countries. So we have to find alternatives, and that's where definitely there is a lot of talk going on. And if I can summarize the Cochrane review and Olson's statement that by virtue of its selective vasodilator effects, inhaled nitric oxide is considered as the mainstay of treatment, but approximately 30% of neonates fail to respond, and some patients' nitric oxide therapy is associated with rebound pulmonary hypertension when therapy is discontinued, when we need alternative drugs, and endogenous nitric oxide is suppressed with this, and certainly complications include methemoglobinemia, and it is a costly treatment for many centers, including resource poor countries, and potential role of inhaled nitric oxide as alternative to inhaled nitric oxide is being explored. What we have done in Cloud9 is we are the largest neonatal and maternal chain hospitals in India. Currently, we have 16 branches. We are, by the end of this year, we will have 24 branches all over India. We have delivered just over 100,000 babies so far. We are part of the Vermont-Oxford network for the last 3 years. We intentionally try to avoid using inhaled nitric oxide by choice. And we have started a multi-center trial with our colleagues drafting the protocol, Dr. Arvind Shenoy and Udayat Kumaran. We are about to start this trial where we are trying magnesium sulfate versus inhaled nitric oxide versus sildenafil. And we have intentionally not used nitric oxide, and we have not lost any baby for the last 4 years without nitric oxide. So nitric oxide is not the magic bullet we thought we used to have, and we have many magic bullets coming up, and that's where it is going to revolutionize, and there's no despair to show because nitric oxide is not available in your countries. So with that, I think I have raised enough questions rather than answers to discuss the topic. And to help us, we have the Trimurtis, I want to call these guys, Praveen Chandrasekharan, Satyan, and Steve Abman. And I request their comments and the way forward. And definitely, we will learn a lot from these trios who are authorities on the management of PPHN. Over to you, Keith.
Yep. Okay. Thank you so much, Dr. Kishore, for that comprehensive review of the current therapies for PPHN. Yeah, it is true. We do have several experts in this field. So perhaps I can invite Dr. Abman, Dr. Satyan, and Dr. Praveen maybe to meet yourself and maybe give some of the perspectives that you have with regards to treatment of PPHN in your centers. Particularly, I'm sort of interested as well with regards to, preterm infants, whether or not you have any thought, Dr. Kishore as well, with regards to, the small babies that we have that are very, that come in that obviously in pulmonary hypertensive crisis, and what specific modalities would use in those sort of situations. Thank you. Maybe Dr. Abman, do you want to start us off? Maybe give us some comments and your thoughts.
Yes, thank you very much, Dr. Kumar. That's a wonderful presentation. And we actually in our center use all of those medications that you mentioned, but it depends on which babies, when, and why. And so let me say that when we think about PPHN and when we started doing the nitric oxide work many, many years ago. Our initial trials, we were so worried about its toxicities because of cell culture studies showing that nitric oxide in alveolar type 2 cells in culture was terribly toxic. And it caused nitrate of stress to cells and was injurious, may cause pulmonary edema. So once the observation was made that it's very important for the normal transition at birth that you release massive amounts of nitric oxide to make the normal transition. And animal models spoke to the failure of NO production as being central. And we could see such selective and potent and sustained vasodilator by simply adding a little gas to the gas you're giving in the ventilator and having that selective effect. That's what led us to start some of the early clinical trials. But because we were so worried about side effects, the babies we selected for the initial studies were those who we tried everything else that we had available at the time. And what we found at the time was that we had about an 80 or 90% success rate in terms of sustained improvement, avoidance of ECMO. But early on, we'd hear from different centers that they weren't seeing that rate of success in terms of reduction in ECMO use. And so it made us reconsider what was so different between sites and centers. And what we found that if you just consider the term baby, how you diagnose PPHN, how you ventilated PPHN babies, what kind of cardiotonic support you targeted and how you used it, how you excluded the left ventricle and its performance as being vital. For assessing responsiveness. The more I travel, make rounds with people, exchange notes, both from animal models and from clinical visits, we realized there was such diversity, such variability. And so if we then move forward 30 years now, and we talk about PPHN, what really still concerns me, even from the past, is the idea that we still have trouble characterizing or phenotyping our babies. When you say PPHN, what are we really talking about? You know, when we talk about PPHN in the preterm baby, especially, what window are you saying? What is it that we're using to target and why? And so in terms of a starting point for what we're doing therapeutically, the idea of who should get it and in what kind of an algorithm, you know, how do we approach the disease diagnostically? How do we think about the three spheres, heart, lung, and vascular, that contribute to PPHN type physiology, how you manage those sets the stage for success or failure. And so to me, that was the fundamental thing. So we talk about PPHN in preterm babies. Just like term babies, they could be very responsive to nitric oxide. But the question is, should they really be getting it? And how do we diagnose it in the preterm baby? Is it sufficient to have just an abnormality by echocardiogram? Do you have to perform echocardiograms? Could you rely purely on pre and post ductal saturations? Do you simply say if you're profoundly hypoxemic and on a ventilator, you must have PPHN? And so we're learning a lot how to better phenotype these preterm babies. And so the way I think about it is what we're targeting and why. And starting off with preterm infants, for example, do they have true PPHN diagnostically? And that's different from a baby who just has a delayed transition of their pulmonary artery pressure over time with a slower recovery. And it's different from a baby who simply has an abnormal echocardiogram in the first days of life, where it turns out it's a biomarker for late pulmonary hypertension. Later in the course, or if they develop BPD. So for me, the most interesting part, I'll try to wrap it up here. The most interesting part of the nitric oxide story was phenotyping makes a difference. How we characterize the physiology and target the primary cause of the hypoxemia, whether it's lung recruitment strategies, cardiac support, or that we're really misdiagnosing other causes. You know, those were so important with this failure rate. But having said that, if we have babies who failed nitric oxide but have sustained pulmonary hypertension we want to treat, we certainly use sildenafil, especially with chronic therapy. We will add it on to nitric oxide. We have experience with bosentan as well. And we certainly will use milrinone, especially in the setting where there's left ventricular dysfunction, because that's where you have pre and post capillary pulmonary hypertension contributing to the shunt. And if you could help the LV unload a bit with milrinone, you could often augment that response to nitric. And thanks.
Thank you. That's actually a very, very important perspective. Dr. Satyan, do you have something to add on to that?
Thank you. Really enjoyed the talk, Kishore. Lovely talk. Steve, thanks for the overview. For those of you who do not know, Dr. Abman is literally Mr. Nitric oxide. He has characterized the use of NO right from the time of birth, and he's the one who conducted the initial experiments which showed the role of nitric oxide in newborn transition at birth. And he has led several efforts with the use of inhaled nitric oxide in pulmonary hypertension. I want to almost counter what Kishore said in saying that nitric oxide is almost a magic bullet. The only problem is that it's a very, very expensive magic bullet. And as Steve was mentioning, in several conditions, nitric oxide is very effective, and the fact that it's a selective agent is what really makes the difference. And since I trained in India, I do visit many institutions in India, and many of you commonly see meconium aspiration syndrome with birth asphyxia as probably the most common cause of PPHN. And in many of these patients, you do see a significant component of systemic hypotension. The issue of systemic hypotension in pulmonary hypertension is very, very common. And anywhere from 25 to 50% of patients with PPHN land upon vasopressors and inotropes. In that situation, the use of a non-selective systemic vasodilator like sildenafil can be detrimental, mainly because it drops systemic blood pressure as well. It is not selective to the lung. So you should be very careful, check the systemic blood pressure, see if there is evidence of left ventricular dysfunction, and make sure these things are addressed with appropriate therapy before you institute oral sildenafil. One concern I have with the use of oral sildenafil is it's widespread use in India. It's commonly used many times, even in instances where no therapy is required. A common scenario would be a baby who is literally a few hours old, who gets an echo done for mild hypoxia, and there is evidence of tricuspid regurgitation. In these patients, it's probably adequate to give a little bit of oxygen and wait to see if the pulmonary hypertension resolves, and make sure the baby declares his or her phenotype before aggressively jumping and treating these babies with an agent that can cause both systemic hypotension and reduction of pulmonary blood pressures. Milrinone, again, is a very useful drug, and it's not, for some reason, as Kishore mentioned, it's not very popular in India, but it's a very useful drug, especially if in babies who have had asphyxia and pulmonary hypertension, if there is evidence of left ventricular dysfunction. Definitely it's a very useful drug. And the rest of the drugs are all very effective, but very few of them are as selective as inhaled nitric oxide. So there are definitely benefits of using inhaled nitric oxide. The only issue is that it's very expensive. Thank you.
Thanks. And finally, I think, Dr. Praveen, do you have anything to add on before we move on to the questions?
Well, thank you so much, Dr. Oi, for inviting me for this talk. Dr. Kishore Kumar, that was a very nice talk, and really enjoyed hearing your perspective of management of pulmonary hypertension. Really, there are only two experts here. One is Dr. Abman, and one is Dr. Lakshman Narasimha. Dr. Satyan Lakshman Narasimha is my mentor, and I really got hooked up to pulmonary hypertension because of him. And Dr. Abman has been a teacher ever since the days of the Cardiology Pulmonary Biology Forum seminar series. And there's a lot of great discussions and a lot of great teaching that he has done for us. So there are only really two experts, but I can share from our single center study that we have done with Dr. Satyan as my mentor when he was here. So the real rude awakening came when 2011, the NIH came up, and NIH and AAP came up saying that there's no real evidence to use inhaled nitric oxide in preterm infants, especially for pulmonary hypertension or hypoxic respiratory failure. And then there was another paper that came from the pediatrics database, which showed that despite these recommendations, inhaled nitric oxide is continuously being used. And so there could be some value to add, like Dr. Satyan mentioned, and Dr. Abman mentioned as well. So we looked at a single center data, and we looked at preterm infants were less than 34 weeks gestational age to see if in less than 28 days old preterm neonates, to exclude pulmonary hypertension secondary to BPD. We wanted to see if there was any value to use inhaled nitric oxide. And so being a single center study with a robust database, we came at a conclusion after analyzing the data that if you had a preterm neonate whose mothers received antenatal steroid, who had preterm prolonged rupture of membrane for greater than 18 hours, and when they had all the ventilatory corrective steps done, including making sure the lungs are adequately ventilated by X-ray evidence and making sure there's no evidence of hypercapnia. When we introduce inhaled nitric oxide, we assess the response by the arterial oxygenation to the fraction of inspired ratio, otherwise called the PF ratio. And then we found out if there's a response of greater than 20, then those infants were highly benefited from inhaled nitric oxide. And so those who did not have response, no matter how long you continue to expose them to inhaled nitric oxide, did not do well in terms of BPD as well as mortality or severe IVH and perinatal leukomalacia. But again, our database was smaller and we didn't have a larger database, and we did attempt to look at it in a different database, but we didn't have every evidence that we needed to come to a conclusion. But that said, the practical difficulty now that we are having in our institution is that after the 2011 NIH statements, like Dr. Kishore Kumar had mentioned in his presentation, the cough, which is a relative contraindication. So since United States follows a multi-payer system, it becomes extremely difficult for reimbursement. And until my mentor was there in Buffalo, all that we spoke about subject, and once he left, all that we speak about is a cost. And now this is a rude awakening when it comes to management. So I think those are something that I can contribute, but I would like to hear more, being a chair of a hospital in India. And when you mentioned that inhaled nitric oxide is a relative contraindication based on cost, how is the payment system there? I do know there are now insurance, and we all almost have representation from 3 continents: Australia, Asia, and United States. This is a practical difficulty in United States with the reimbursements, especially when the bills are submitted after the infant has achieved treatment. So I'd like to know the perspective from Asia as well as Australia as to how a inhaled nitric oxide is offered, and what is this relative contraindication based on cost?
Yeah, thanks, Praveen. I think I can say that you guys are Trimurtis, Steve Abman, Satyan, and Praveen. And I can see Nadia Badavi is also there. I'm sure she's one of the experts. Nadia, do you want to say something before I jump in to answer Praveen's question about inhaled nitric oxide? You're nodding your head off.
No, I was just saying that I'm delighted that in Australia, the cost doesn't really come into it. That's all I was thinking. But thank you very much. You've made me think about our use of nitric oxide. We do use it quite a bit, mainly for diaphragmatic hernias. That's our biggest use. I think some of my colleagues, maybe Himanshu and Stephanie, are on as well. Do you want to comment, Stephanie? I think she's on. Stephanie Boyd.
Praveen, to answer your question about the cost, see what we have done is we have nitric oxide available. But what happens is the cost of treatment is so high. The moment we explain that to the parents, they say, is there no other treatment available? So that becomes an ethical dilemma. I mean, is there no other treatment available? Can I confidently say there's no other treatment available? Then we have to say, yes, we have alternatives, and if they don't respond, we'll put this on. So many times the decision is taken by the parents rather than the neonatologist. Unless we think we are losing the baby, then we jump into nitric oxide. Majority of the cost of treatment is borne by the parents, and many times the insurance agencies decline the reimbursement of the cost of neonatal treatment because there's a small print in the insurance which says that any congenital condition is not covered by the insurance. And many doctors in the insurance panel who describe PPHN as a congenital condition, and we have a battle in fighting with the insurance to get the parents help the insurance, which is another battle. And parents who can't afford nitric oxide treatment, we have crowdfunding available. So money is not the factor. Money is not the factor. It's the psychological barrier that this is expensive. And initially parents are responding, subsequently say when the baby becomes very sick, they will say, oh, maybe you should use it and things like that. So what is important is we don't lose the babies just because of a cost. Many a times we may forgo the cost. So to answer your question in simple words, yes, it is a parental responsibility. Insurance does exist, but they do decline many a times. And I don't know what is your experience in the US. Here it described as a congenital abnormality, inverted commas, and they decline on that basis. Maybe Steve and Samuel Rajatharai I can see here can answer those two questions in their respective countries.
Yeah, I think maybe we can get Prof. Sam from Singapore. Maybe he can give a perspective. I see that he's also wanted to make a comment.
Thanks, Kishore, for your excellent, up-to-date, review, and for the opportunity to share. I always learn from Professor Steve Ubman and also Prof. Satyan whenever I listen to their lectures. Always they teach us new things. And I share the knowledge, not only in Singapore, but the regional countries. Unfortunately, Prof. Ubman was in Singapore only for 2 days, and he made a short visit to our hospital. Okay, I would like to make the comment. And you see, nitric oxide wasn't available in Singapore until October 2002. We were using magnesium sulfate. I think it is not the pulmonary, vasodilator. The first thing is supportive care. This is very essential, and the supportive care of the baby and adequate ventilation. Try gentle ventilation, and if there is a bad lung disease, I think the first paper by Ubman and Kinsella on, recruitment of the lung. If the lungs are not properly recruited, nitric oxide won't work. So recruit the lungs. With regard to meconium aspiration syndrome, meconium is a very powerful inhibitor of surfactant. And we use previously Cervanta, and now we use Curosaf. Sometimes 3 doses. Higher doses are needed, because of the, inhibition of the, surfactant, and many babies, respond. And with this, we were using magnesium sulfate. We published or presented our data in the San Francisco, PAS conference, 1999. It's published, in the abstract book. But one of the important thing is it causes systemic hypotension or worsens the systemic hypotension. 70% of the babies had hypotension. Prim the circulation with normal saline, and then use loading dose as a slow infusion, then gradually increase. And other complications we came across was hypocalcemia and hypokalemia, which needs to be watched for. And when you use magnesium sulfate, it also causes something like a transient paralysis-like effect at the neuromuscular, junction. So don't use any additional, agents. It was helpful. We didn't we saw the response rate of about similar to nitric oxide, about 70%. And rapid response within 1 hour was about 50%. The other comment I would like to make, what I see here and the regional countries is, what Professor Abman and also Professor Satyan commented is they refer to the very preterm. What we see is late preterm. In the Asian countries, and diabetes is very common. In Singapore, gestational diabetes is about 15 to 20%. And nowadays we have a proper screening, universal screening, no longer selective screening, adequate control, and it modifies, which is not there modifies the outcome, which is not there in the regional countries. And IDM babies can have primary hypertension, pulmonary hypertension, or RDS with secondary pulmonary hypertension. So in this scenario, the late preterms, in my experience, about 30% has associated pulmonary hypertension. So one need to treat that, in addition to adequate ventilation and surfactant therapy, treat the pulmonary, hypertension. One can't give surfactant and extubate such babies. So that is, very important. And hypertrophic, cardiomyopathy. That can mimic congenital or the hereditary, cardiomyopathy. This is very often inadequate treatment of diabetes in the mother, and the babies are large for gestational age babies with septal hypertrophies. They have pulmonary hypertension. And in this situation, don't use dopamine. Dobutamine may worsen the situation. We may have to use milrinone and beta blocker. Otherwise, you may lose the baby. And so now, very preterm infants, we do see in Singapore 26 weeks and below after prolonged leak, they do have pulmonary hypertension, even otherwise, associated with chorioamnionitis, healthy appearing lungs. And in this scenario, I always recommend try low dose nitric oxide. I learned from Professor Nick Evans, Australia. And we started 5 parts per million. Look for the response and be prepared to wean rapidly. Repeat the functional echocardiogram 12 hours early. Otherwise your lung gets flooded. We have lost, I always warn the registrar, the fellow, if they don't take heed to the warning, what happens is pulmonary hemorrhage baby may die. So one need to be watchful in preterm babies. As Professor Abman said, it is a different form of, whether it's a PPHN or not, I don't know. But beware of pulmonary hemorrhage. Thank you. Yeah.
Okay. Thanks, Prof. Sam. I just wanted to pick up on some questions here. We're kind of running out of time here. Can I pick up on the question by Dr. DeWall that brings back to the point that Dr. Abman mentioned earlier on the efficacy of medications in PPHN is very dependent on the underlying physiology and the predominant determinant of the hypoxia. So how can we make sure that in future trials that this can be categorized? Dr. Kishore, do you have any comments on that? And also to the group as well.
Yeah, I think Kurt has definitely raised a good pertinent question, and that comes to the level of indications of the drugs used. As I mentioned, in the beginning of the lecture, the slides which I had drawn from Satyan's articles, that nitric oxide is not necessarily indicated for all things. Similarly, the mechanisms of the cause of hypoxic respiratory failure has to be addressed first before we start using the drugs. I agree with Satyan's observation that probably sildenafil is overused in India. The moment they see saturation dipping, they start using even before they use surfactant, for example, in meconium aspiration. So I think we have to rationalize the use of the drugs. We have to see one thing is very clear, that the world is not united in the management of PPHN, because what has happened is the Americas, Australias, and New Zealand have no problem with the cost, and they have no problem with the medical grade nitric oxide. So they don't think anything other than nitric oxide and they use it. In the resourceful poor countries, they always try to find the alternatives. And if you look at the whole literature of sildenafil, it comes from Middle East and Asia. And if you look at milrinone, it all comes from Canada and parts of Europe. So we have to be united in the approach of PPHN, and being neonatology, one of the youngest branches of medicine, I think we have enough reasons to join hands all over the world and use a common protocol and probably design an indication for what drugs and what indications, and sub-delineate the uses of these drugs in various indications. Then only we will have an answer, especially to the pertinent questions by people like Kurt. So at this stage, I don't think we have an answer. I hope I've answered the question, but not answered.
All right. I think that's okay. We will because I'm just mindful of the time. I think that we are really at the end of the talk. Thank you so much for that very informative lecture, Dr. Kishore. I think any unanswered questions we will circulate among the Dr. Kishore and then the other